First of all, I'd like to thank the organizers of this 23rd Conference of Indian Society of Neuroanesthesiology and Critical Care for this opportunity to talk in this oration session. I bring the greetings from the Nepalese Society of Critical Care Medicine, from the Society of Anesthesiologists of Nepal, and from Neurocritical Society. I'll be discussing and talking about bridging the evidence-practice gap in neurocritical care in resource-limited settings. I have nothing to disclose, and I don't have any conflict of interest for this talk. So I'd like to start with the burden of neurocritical illness, how it is globally and how it is in our part of the world. So if we see this paper published in Lancet in Neurology in 2019, they have reviewed the burden of neurological disorders globally and as well as regionally, and they have also looked after the trend of the burden of disease neurological disorders. And it is seen that in 2016, neurological disorders have become the leading cause of disability-adjusted life years, and it is a second leading cause of death globally. And also, it is interesting to note that over these 30 years duration of time between 1990 and 2016, the absolute number of deaths attributable to neurological disorders increased by 39%, and disability-adjusted life years also increased by 15%. That means globally the burden of neurocritical illness is increasing. And among the top 4 neurological disorders that have contributed significantly to the disability-adjusted life years, we can see that the first contributor is stroke, and the fourth is the meningitis. These 2 disorders are of clinical significance from the neurocritical care perspective. So if we see the scenario of India, we can see that this paper that was published in Lancet Global Health in 2021, where they have reviewed the neurological burden of disease attributable to neurological disorders in the various regions of India. And they have also compared how the burden of disease of the neurological disorders have evolved over these 20 years duration of time, 30 years duration of time. And you can see that the burden of neurological disorders is mainly due to the non-communicable disorders like stroke, and the disability-adjusted life years have almost doubled over this 30 years duration of time between 1990 and 2019. It was 4% initially in 1990, and it has increased to 8.2% in 2019. And the contribution from the injury-related neurological disorders like the traumatic brain injury to disability-adjusted life years has also increased almost 3-fold in this 30 years duration of time, from 0.2% to 0.6%. And among the top 3 contributors for disability-adjusted life years, stroke contributes for almost 40%, and then second is epilepsy, and the third is encephalitis, contributing for 5.3%. All of these 3 contributors are of significance from the neurocritical care point of view. And also it is important to note that the neurocritical illness is disproportionately higher in low-income countries and in places with resource limitation as compared to high-income nations. If we see over the past decades, we can see that neurocritical care has emerged as a distinct specialty. If we see the history, and if we go back to 1980s, this specialty initially it started as dedicated post-operative monitoring units for neurosurgical patients, where they found that if the post-operative neurosurgical patients were cohorted in a dedicated unit where there were the trained staffs capable of monitoring these patients effectively, then the outcome of these patients were possibly improved. And the neurocritical care, this specialty has emerged, especially in the last decades. And if we see how it has emerged in the United States in the last decade, we can find that there was a formation of the multidisciplinary Neurocritical Society in 2003, where they involved the healthcare workers related to neurosciences from various specialties like neurology, neurosurgery, intensive care, anesthesiology, and also other healthcare workers like nurse practitioners, pharmacists, and so on. And together they created this society in 2003. And also you can see that in 2005, the neurocritical care has gained a full acceptance by the United Councils of neurological subspecialties as a distinct subspecialty. So it has evolved in a very good way in the United States in the last decade. And after the formation of this Neurocritical Society, they have also created various regional chapters. So far, they have 4 chapters. The Asia Oceanic chapters, which is the largest of all these 4 chapters. The next is the Middle East, North and Central American, and the South American chapters. And the objective of these various chapters is for the international collaborations with respect to the research, enhancing the neurocritical services, and so on. And also we can see in our part of the world as well, this specialty has gradually evolved, but yet it has lagged behind as compared to other specialties. In country like India, now there are multiple centers who have which have dedicated training programs for various specialties related to neurocritical care. However, in many part of the resource-limited settings, there are very limited healthcare workers that are trained in this specialty. So let's go back and look after the evidences in favor of dedicated neurocritical care unit. Does it actually help or not? And how, if so, how it helps? So this is seen that the introduction of a neurocritical care team with a neurointensivist is associated with reduction in hospital mortality and ICU length of stay without increasing the readmission. This was an interesting paper published by the Suarez and colleagues in 2006. And also it is seen that the high intensity ICU staffing with mandatory intensivist consultations or with the closed ICU intensive care units, they are associated with improved outcomes in the patients with neurological and neurocritical disorders. So we can see that when the patients are treated in dedicated neuro ICU, the mortality of the patients are improved in the various ranges of the Apache quartiles. Also, we can see the better survival of these patients when the patients were being treated in dedicated neuro ICUs as compared to when the patients were treated in the general intensive care units. So this is a list of various studies. Most of them are cohort studies with historical controls. You can see that the introduction of dedicated neuro intensive care units, generally they are associated with improved outcome in the patients in the form of decreased mortality and ICU stay, as I just discussed. And also we can see that if we can see that in this summary of various studies in which the effect of dedicated neurocritical services on mortality were compared, we can see that the introduction of dedicated neuro ICU was associated with decreased mortality in various neurocritical disorders like traumatic brain injury, intracerebral hemorrhage, subacute hemorrhage, general neurointensive care unit, and so on. So it is obvious that the burden of neurocritical illness is significant globally and more so in the places with limited resources. And also we know that the dedicated neuro ICU helps in improving the outcome of these patients. And also we can find various evidence-based practice guidelines in the field of neurology, neuroscience, and neurocritical care overall, like this good guidelines on ischemic stroke. So we have good quality evidence that is emerging for the care of the patients with neurocritical illness. And recently in 2018, there was a statement for healthcare workers from Neurocritical Society, where they have published the standards for neuro ICU, how the neuro ICU should look like, how should the organization and design of neuro ICU should be, and they've categorized the neuro ICU into various levels like level 1, 2, and 3. And level 1 is, as mentioned by them, the level 1 will be the ICUs, neuro ICUs with the highest level of care that will be capable of dealing with the most sickest of the neurocritically ill patients. And those ICUs would also have the academic programs dedicated for training and competency development for the experts in the field of neurocritical care. Level 2 neuro ICUs would be able to stabilize the patients with neurocritical disorders and would be able to manage the stable neuro ICU patients. And level 3 ICUs are categorized as those units, neuro ICUs, that are capable of stabilizing the patients with neurocritical disorders, and there should be good communication between these three levels of ICU, so that then they can have a good system of referral. So they have various sections describing how the organization of these ICUs should be, how should the policies and guidelines should be in these ICUs, the healthcare workers, the various specialties of the healthcare workers to be involved in the neuro ICUs, the ratio of those staffs over there, supporting specialties, facilities, diagnostic facilities, the need of equipments, monitorings, and the need of research and trainings. So we have a good amount of evidences as well as guidelines as how the neurocritical ill patients should be managed in the ideal scenario. But if we see the scenario in the resource-limited settings, we can find a significant gap between these evidences and what actually we find in our real-world scenario. If we see about the management of stroke in the resource-limited settings in LMICs, low and middle-income countries, this part of the world has a higher burden of stroke. 60% of the global burden of stroke lies in these low and middle-income countries, and the mortality is also higher in this part of the world attributed to stroke. Almost 70% of stroke mortality occurs in this part of the world, and we can also see that the patients with stroke, they present with higher severity in this part of the world, and as compared to the high-income countries, the proportion of the patients presenting with intracerebral hemorrhage is higher as compared to acute ischemic stroke. So the barriers in stroke management, there are the various levels, starting from the pre-hospital level, because of the lack of the stroke helplines, because of lack of awareness among the general public about stroke, insufficient infrastructures, and inadequate pre-hospital transportation facilities, like the lack of ambulance services, lack of emergency medical services for the proper and rapid transportation of patients in the pre-hospital setting. Also, in the hospital setting, the resources are limited in emergency departments. There are limited resources related to the imaging and radiology. And also regarding the stroke units, there's a significant lack of trained neurologists, stroke experts, and personnel trained in managing the stroke and other neurological disorders. And also the cost of the drugs that are required for managing these patients are usually high, and often out of reach of general public to afford for these. So we can see that globally the public awareness of stroke remains low, and the awareness is even lower in our part of the world, like in India also. The stroke awareness among the public is significantly lower. And it is seen that the community stroke awareness education programs can help to raise awareness significantly, and it can thus delay the lag between the symptom onset and presentation of patients to the hospitals. And for this purpose, television programs, newspapers, books, magazines, and various online resources can be of help as well. As you know, the stroke management in this part of the world is costlier. It's associated with significant morbidity and mortality. one of the important steps for decreasing the burden of disease and associated morbidity should be to focus on the primary prevention. And as you know, in this part of the world, many patients presenting with stroke, they have the significant risk factors like hypertension, smoking, diabetes, obesity, atrial fibrillations. They're often not diagnosed or they're poorly managed, thus also contributing to a higher burden of this specific neurological disorder. Also, we can see that the risk factor like diabetes is increasing significantly in the general population, and in the last decades, it has increased by almost 3 or 4 folds among the general publics. Also, we can see that the cost of management like a stroke and secondary prevention is high. This also applies to the road traffic accidents. As I mentioned earlier on, in the last 3 decades, the incidence of the traumatic cause of neurological disorders, that is traumatic brain injury, has almost increased by 3 folds, and that is mostly attributable to road traffic accidents. So the preventive measures to minimize road traffic accidents can also help to decrease the burden of disease, and also the vaccination program, especially for the meningococcal disease, can help decrease the infectious cause of neurocritical illness, and thus the burden of disease from that cause as well. If we see the pre-hospital transportation and emergency medical services from this paper published in 2016 by Panjan and colleagues, the most of the pre-hospital transportation is by the means of the personal vehicles, taxis, auto rickshaws, and only around 12% of the pre-hospital transportation was by the dedicated ambulance. And this was one of the significant causes responsible for the delayed presentation of the patients with stroke to the emergency unit. So this is what we actually expect and what we dream of, and this is what is the standard of care. Like there should be dedicated rapid transportation of patients in the form of the heli rescue, ranging from heli rescue to the dedicated, very sophisticated ambulance and EMS services. But if you see in our part of the world, often we can see this type of scenario, especially in the rural regions, where the transportation of these patients is really challenging. They are often transported, the sick patients are often transported by being carried by the friends and relatives, in part because of the geographical challenges, because of the very primitive development of the roads and primitive EMS and hospital transportation systems. So this is one of the big challenges, and because of this also the many patients with stroke and other neurocritical illnesses, they arrive to hospitals, they arrive to the attention of medical services pretty late, and usually they present with more severe illness and in the later course of the critical illness. So it is important to train the paramedics, and it's important to train the EMS nurses, and also it is important to overcome these unique challenges if we are to receive these patients on time, and thus to improve the outcome of these patients. So if we look at the access to the CT scanners, we can see that the number of CT scanners per 1 million population is remarkably lower. That is just 1.3 CT scanners are dedicated to each million population in low-income countries, as compared to 21.2 scanners per 1 million population in high-income countries. Also, at the same time, in the low-income countries, we can find that these CT scanners, they are not uniformly distributed, and most of these scanners are located in the major cities and academic centers, and then also the cost of CT scanners is usually high, and also some of those scanners they are non-functional. In the low-income countries, many equipments are being donated by the other nations or by the donating bodies, and after installation of these devices, usually the maintenance of these devices are not performed regularly. There's because in part because of the lack of the services that can provide the servicing that can provide repairing of these devices if they become damaged. And thus, we often find that there are equipments, but there are this might be non-functional, and that can also be responsible for the limited access to the CT scan in these patients. Also, we can see that most neurological emergencies and neurocritical illnesses are managed by the healthcare workers with no specialized trainings, and also there are limited trained healthcare workers in the low and middle income countries. Like there are a very limited number of people with training in the neurosciences. We have a limited number of neurologists, neurosurgeons, neurointensivists, and so on. And also, despite the growing evidence in favor of dedicated neurocritical units, the dedicated neuro ICUs in this part of the world are largely limited to the major centers. Both those centers are usually the private centers that are quite expensive for the general publics. And this was one study from Nepal, published in 2019, where we looked retrospectively looked after the patients presenting with acute ischemic stroke in a tertiary level teaching hospital over the duration of 1 year, and we found that of all the patients presenting with ischemic stroke, only 20% of patients they arrived within the time frame of thrombolysis. Again, those patients who presented within the time frame, only 13% of those patients actually received the thrombolysis. One of the main reasons, one of the main barriers why they couldn't receive thrombolysis was because of the cost of the treatment, because of the cost of the drug alteplase. So if we see the effectiveness of various interventions increase the rate of thrombolysis, we can see that if we can raise the public education, public awareness, if we can enhance the services of the emergency medical services, and if we can introduce the telemedicine, these interventions can potentially increase the rate of thrombolysis and thus potentially may improve the outcome of the patients with acute ischemic stroke. So how can we effectively narrow the wide these interventions gap between the evidence and practice? The gap is even wider in this part of the world with limited resources. So first, it is important to identify the specific barriers for adoption of the guidelines, and then to design the interventions to purposefully overcome them. Also, it is very important to meticulously consider local context and appropriateness while designing the interventions. Often the standard guidelines that are derived from that are designed and formulated based on the studies and research in the high-income countries may not be directly applicable to the places with the resource limitations. So it is important while formulating the local policies and while adopting the guidelines in the places with limited resources. And it is important to implement the quality improvement interventions, and these interventions should be tested with the well-designed trials, and then only these interventions can be actually translated into the clinical practice, and the well-designed knowledge translation research can significantly help in implementing these guidelines and thus narrowing the evidence practice gaps. This is one example of a very well-designed study regarding the effectiveness of multifaceted quality improvement interventions on the hospital personal adherence to the performance measures in patients with acute ischemic stroke in China. It is also called as Golden Bridge acute ischemic stroke trial that was published in JAMA, where they randomized a total of 40 hospitals. The 20 hospitals were categorized into the intervention arm, enrolling almost 2,400 patients, and in this intervention group, the involved centers. In the involved centers, they applied the quality improvement interventions in the form of the clinical pathways, dedicated care protocols, quality coordinator oversight, performance monitoring and oversights. And in the 20 hospitals that were considered as a control group, they provided usual care. And they found that the quality improvement interventions significantly yielded the better adherence with the evidence-based performance measures, and also they improved the patient outcomes and decreased the mortality in the 3, 6, and 12 months follow-up. So this was a paper published where they did the literature review regarding the trends in publications regarding the evidence practice gaps. So they reviewed the data over the 10 years duration, and they studied they reviewed the publications related to the evidence practicing gap that are related to the nine guidelines related to various medical conditions. And basically they categorize the interventional studies into 2 categories. The first category was well-designed studies that met the effective practice and organizational care criteria. And the next category was other studies that didn't meet this EPOC criteria. So the studies that met this well-designed EPOC study criteria were either the randomized control trials, patient randomized or cluster randomized, or the non-randomized control trials that are quasi-randomized, or the studies that were controlled before and after studies, or the studies and then that were of the interrupted time series design. So it was interesting to see that more than half of these evidence practice gap studies were of the descriptive design. And of note, these study designs, they help to elicit the problems, elicit the existing gaps and reasons of gaps, but they don't help to know how those gaps can be minimized and what type of interventions can help. And only about 15% of the studies were of the interventional type. And of those interventional studies, only 30% of those met the EPOC criteria. So you can see that only a limited amount of the studies that are being performed in this field of evidence practice gap were of interventional design, study design, and among that also a very small fraction of those interventional studies are actually well designed studies. And also we can see that the patient participation in these well designed studies are low. The expected patient participation is more than 75%, but we can see that only 60% of those studies were actually participated by the physicians. I was going through this interesting editorial that was published in the American Journal of Critical Care, and it is interesting to notice that it takes in an average of around 17 years for a good quality research to be translated into practice. So this is a long duration of time, and that usually the clinicians take to adapt the available evidence into the practice. So what is needed is we need to promote a translational science. Basically, there are 2 types of translation. One is to convert the basic science understandings to the testable clinical research, and the next step of translation would be to implement the clinical research, to implement the available guidelines, available understandings, available research findings into the practice. And actually, this type of translation helps in changing the clinical practice. And so, in the United States, they have formulated this National Center for Advancing Translational Sciences, NCATS, and that is dedicated to improve the translation of these evidence bases into the clinical practice. And at the same time, to improve this translation of available evidence into the clinical real-world scenario, we need the larger multi-site studies that generates a well-designed, that generates the good quality evidence in the context where the evidence need to be applied, and also the newer trial designs, like adaptive trial designs, step-based design, and comparative effective analysis can also help to generate good quality evidences that are appropriate to the local context and local resource availability. So regarding the perspective of resource-limited settings, we have the unique challenges. We have very much limited research availability, the guidelines, as I mentioned earlier, and the standard practice guidelines that are designed and published based on the research from the Western world may not be directly applicable, and the evidence practice gap that exists in this field of neurocritical care globally seems to be even wider in the places with resource limitations. So in the efforts to narrow the gap and in the efforts to increase and train peoples in the field of neurosciences, neurocritical illness, we try to, with this small study, to explore if this emergency neurological life support course is applicable in the low-income countries or not. So this was published in 2018, and what we did was that we did a prospective course study on this first ENLS course that was conducted in Asia in 2015 in Nepal, and we tried to explore whether this ENLS course that was designed and formulated by the Neurocritical Society is applicable in this part of the world, and whether it is helpful or not. And we try to explore the knowledge and decision-making skills that was assessed at baseline immediately after the course and after 6 months following the course completion, and we could find that this course was helpful in improving the knowledge and decision-making skills among the participants, and this improvement, this change was retained even at 6 months. Also, we shared our experience regarding the endovascular management of acute ischemic stroke in Nepal. It was published in Lancet Global Health. Actually, we shared our experience of the initial 20 patients. It was a single center experience. But our major focus in this paper was about how we can, what are the barriers, what are the potential barriers regarding the expansion of these services, and how we can overcome those barriers to expand this mechanical thrombectomy services to the larger patient populations, not being limited to a single center. And we mentioned various possible steps that can help, like the need to raise public awareness, need to develop the pre-hospital transport system, the need of multidisciplinary approach, need for the local policy and protocols, need for support from the local governments. Definitely we need the funding supports, and we need more trained healthcare workers. And also it is important to link the comprehensive stroke center to the various satellite centers, and the telestroke services can also be of help to expand this highly specialized stroke management services. So how we are moving ahead, I'm going to mention about how our center is moving ahead in the managing of stroke patients. Our center is a dedicated tertiary level teaching hospital, one of the largest hospital in the capital. So what we did to move ahead was we created a multidisciplinary stroke committee that comprised of neurologists, neurointensivists, neuroanesthesiologists, radiology team, as well as a neurosurgical team. And then the committee worked together to develop a institutional stroke protocol that was approved by the hospital. And we also initiated the dedicated stroke unit in our center. And we are planning to implement this, formally implement the protocols for the patients arriving in our hospitals very soon. And the next step would be to expand this service to other centers as well. And for that, we are collaborating with the local hospitals for the support, and also we are planning to function. Our center is planning to function as the hub hospitals, and our hospital will be providing the stroke services, both the referral services and also the telestroke services for the 13 centers of the province. And we are planning to begin this service from one province initially, and then if this project would be successful, then possibly the similar process will be launched in other provinces of the country as well. And also we are collaborating for the government funding, because one of the major barriers in the management of stroke patients has been the lack of fundings and the cost of the drugs. And the dialogue has been very fruitful so far. We are also planning to train and educate the healthcare workers of those 13 centers. We are planning to train the frontline healthcare workers who will be dealing with the stroke patients over there. And at the same time, we'll also be doing the translational research, and we'll be doing various audits to explore whether the program is functioning well or not, to explore the various barriers. And then we'll be trying to narrow those gaps and move ahead with that. Also, we're planning to start the stroke registry in our center, and also we'll be collaborating with the various other centers, major centers in the capital for starting the stroke registry. And the future will be in the future we'll be starting the TBI and acute brain injury registry as well. And also we're planning for the international collaboration and the various global partners so that we can move ahead. And also we will be planning for the specialized training services in our centers in the future. Just to summarize, the evidence-practice gap exists in neurocritical care globally. The gaps are wider in resource-limited settings, attributed to a multitude of unique challenges. The orchestrated multidisciplinary approach to narrow the gaps and to translate the available evidences into clinical practice is crucial to improve the patient outcome. Thank you.